This place is phenomenal. I really owe a lot of my training and my abilities to just practicing up here. So I hope you all took advantage of this weekend because it was phenomenal. Let me just make sure. So I have no disclosures. So why are you all here? Some of us are here because we want to just have a predominantly spine practice. Some of us are here because we want to just add to our practice. We want to be cranial surgeons, but you know, the bread and butter of neurosurgery is spine. So no one has an 100% cranial practice, not even the greats of neurosurgery. So what is the goal of a successful spine surgeon? Well, you want to, of course, give excellent care to every single one of your patients. And as you learned this weekend, you want to know when to operate. And the most important quote that I've been given was the decision's more important than the incision, right? Technically, you could go to the lab, you could throw in thousands of screws, you could throw in screws with your eyes closed. But if that doesn't help the patient, like Dr. Hart suggested, then what's the point of doing it? After that, once you know that the decision to operate is made, what will I find? Sometimes, you know, with a preoperative scan that's a virgin back, which are few and far between these days, you know what you're going to find. But how about the 1,000 redo cases? Was there a CSF leak? Is the instrumentation I know the right one? So there's a lot of different parts to this. And of course, what am I getting myself into? So then I kind of broke it up into the preoperative, perioperative rather, am I at the right level? Is my instrumentation placed correctly? And is everything that should be removed already removed? Postoperative, is my instrumentation still at the right spot? We've seen many examples where it migrates. And how does my construct look, and does that help my patient? And of course, the most important is, once I'm done, could I get some sleep at night? So how do I get to those goals? I think one of the most important things that are kind of missed at spine conferences is the actual imaging. And what do I see on that imaging? So I was sitting in your shoes. This is my 5th One Spine course. And when I was sitting in your shoes, I'm like, wow, now I finally figure out if I could operate. Now I know if I could throw in screws. But what about when I'm done? What does it look like? Because 90% of the time when you do a case and you may have a complication, you're unsure, you get an MRI, and what does it read? Epidural hematoma, postoperative changes, clinical correlation recommended. So that gives you absolutely nothing. So you have to be ready to make those decisions. So a buddy of mine from med school, Daniel Gannat, approached me and said, hey, do you want to help out? And we wrote an entire book. We did the spine chapter, but for the neurosurgeons, this is a very, very important book because it goes through everything from cranial to spine. It's got a chapter on our favorite parts, which are shunts. So I think it's kind of the way of the future, and you just really need to understand where you're going. So when I break it up, you want your preoperative. So I call this the prepared stage. You want to do your preoperative work first. You want to know what to expect. You want to know, do I have all the tools? What does the spine look like? What are my goals? Where could I be fooled? And then, we all have perfect cases 100% of the time, right? No, we don't. So we want to know, if there is a disaster, what are my exit strategies to safely get the patient off the table? Then the next part is your perioperative work, and I call this the periscope, because when you're operating, what do? Your head is in the wound 100% of the time. Even when I was at that synaptive station and I was telling people, look up at the screen, people are still looking at inside the wound and using the screen as reference, not the opposite way. So with that, you want to really rely and understand your radiology, both your navigation and your fluoro, depending on what you have at your institution. And then if you're in doubt, step away from the wound, pay attention to your radiology. And obviously, we are not always perfect. When I was in Dr. Escuian's room, if I said, I think that looks okay, you got a beating. So, you have to, if you think it looks okay and you're not sure, redo it. If you're not sure on your image, get another image. Okay, if your AP is not working, get a lateral. If your lateral is not working, get an AP. If it's pre-op, get a CT image. Okay? And if all else fails, call Dr. Tubbs and ask what you think about the anatomy. So this is a picture of how I spent the majority of my fellowship here. So when you get postoperative imaging, it's when, because some people will do it every single time, some people won't, some people will do it on special cases. For what? What do you expect? And what are you going to do if there's something you don't expect on there? Do you take the patient immediately back to the OR? Do you wait a few hours and see how they do? So I'm going to run through a bunch of pictures just to see what you could potentially see in your postoperative cases. So anyone, what is this? This is a postoperative case of what? It's a CT of what? Good. So that was obvious, right? Pretty easy. How about this? You did a postoperative big lammy, not saying that's the right or wrong thing to do for this, but you get this hyper dense thing, right? What is that? It's a duroplasty, right? You have to know what these things look like. Did I leave something in there? Is that a sponge? No, it's just your duroplasty. How about patient comes back to you 5 years later complaining of back pain, leg pain, and you see this scan, you're like, well, it's probably nothing there, right? We took care of the problem. But how about they still come back and radiologist reads this as another disc, right? You didn't do the first surgery. Your partner down the street did it, or your colleague down the street did it. You didn't know he left a bunch of Surgicel in there. So you have to be aware of all these possibilities, because when you go in there, you don't know what you're going to find. So this is an example, well-placed expandable cage. And, there's dozens and dozens of different companies that have them. There's one that's subsided a little bit, right? So, you have to see where the construct takes you. Okay, you don't want to use a cage. Here, Jens Chapman uses fibrillar strut grafts a lot. Are you prepared to take it out? Do you know which direction it's facing? How about if it just completely popped out? You have to be aware of all these things. How about if you have a stackable cage in there? If you have a stackable cage, do you know what company it is? Do you know how to take it out? Is it stuck in there? Do you have to drill it out? Now, Dr. Kazemi is going to talk in a few minutes about all the different products and expand for fusion. But do you know what those products look like when you're actually looking at a post-op scan? Here's just bone graft from an iliac donor. And, you always say, oh, there's no pain from the donor site. Well, that looks pretty painful there. So, if you're not, if you have other options, you may consider that. And we'll leave that to Dr. Kazemi to tell us. Very cheap option. Cheap for the patient or for the individual? You could also have bone chips in there, but this is what your ultimate goal is, right? It's a mature bone fusion. You want that patient to be happy, nothing really going on. You could also have DBX there. How about BMP? And you could have BMP that induces osteolysis, which is obviously not the most ideal situation. Now this is an ACDF, looks good, everyone's happy. You get a Jason level disease, you have to know what you're taking out. Are you taking out a plate? Or are you taking out LDR? Are you prepared to take out an LDR? Do you know how to take out the wings? So some more stuff you could see. So, Dr. Kazemi in his first talk spoke about the history of spinal instrumentation. And he touched on the major ones, but there's so much instrumentation out there that we're not aware of. Not because we're not studied, but all over the world. You'll see patients from all over the world. You'll see patients from all over the country. And as residents, you're probably used to 2 or 3 or 4 different systems, whatever you use at the hospital. You're not gonna see every single systems. Have you seen the Canada device? Do you know how to take it out? Do you know how it was put in? How about the Vantage plate? How about hooks? Everyone talks about hooks as a good method for PJK. Which direction are your hooks facing? If you have an inferior facing hook and you're trying to take it out by pulling it out inferiorly, you're not going anywhere. What I do before every case is if I know I have certain instrumentation, I'll make a little cheat sheet and put it on my fluoro machine and say, at this level, this is the way the hook is facing. At that level, this is the screw and the size of screw I want to put in. You know, how about facet screws? Do you guys use them at your institutions? They're not widely used, but, you know, at some institutions, they use them all the time. How about these? What are these things? Exactly, right? How about the Lukey rod with a Galveston technique that was previously described? Or you have a Harrington rod. Are you prepared to take those out? How far do you need to do? Or how far do you need to go? Then there's the knot rod. How many people have heard of a knot rod? Okay. So here's a little description of all the different types of rods, different plates. You know, you think you've heard of everything, because the most common one people will see are Lukey or Harrington rods. But there's so many different ones that have been put in through the years. There's vertebral stapling. As Dr. Hart described yesterday, there's the Vector expandable titanium, the device for the titanium rib. I mean, I've never put one of these in, but I've seen them on scans. So then the next topic is interbody fusions. If you have to redo an interbody fusion, what's really important, you know, Dr. Askuian hit the nail on the head in his talk the other day, is you have to know also how it was put in order to know how to take it out. You have the original threaded cages, depending on which company made them. These are Ray cages. You have the old LT cages from Medtronic. You know, this is put in anteriorly. Are you ready to take that out posteriorly, or is there another method you need to do that? Then you have the difference between a PLIF and a T-lift, depending on the angulation of the cage. What happens if your T-lift pops out? How about this cage? How is this one put in? There you go. We learned something this weekend from Dr. Askuian. You made him proud. Then you put in a lateral cage. Did you throw in screws? Do those need to come out? Which direction was the cage put in? You could have anterior cages put in, and then in this particular one, it popped out on the flip. So you probably should have realized that intraoperatively, which is kind of my whole periscope analogy. If you actually paid attention to what's happening anteriorly, you shouldn't be seeing this on a post-op film. How about this? How many people have heard of the axial lift? So, yep. Not really done that much. But I will tell you, having revised a couple of these here as a fellow, that's probably one of the toughest things to pull out when you're trying to do a revision. Make sure you have a very, very good access surgeon for these. We talked about arthroplasties. They're all great, but do you know which ones you have? Which one's in there? You could have the Prestige, and this one shows a nice flexion extension with preservation of motion. You could have the Charity. How about the ProDisc? Because each of these are placed differently. So if you have to remove them, you have to think through that because they'll be removed differently. How about here? What's going on here? You've got a perfect post-op scan on the left. What happened on the right? That scan, I wasn't part of this case, but this was at a Chicago program. That scan was actually 2 weeks later. So. And you've got an artificial disc. What if it fuses? You got to be prepared for all these, right? When do you get a scan? And what do you tell your patient? This is another interesting one. I haven't used many of these, but the posterior dynamic stabilization devices. How many people have seen an isobar? No? But if you do see a scan of it, you've got to be prepared for that. More people will probably raise their hands for an X-stop, right? Because we've been seeing a lot of those come back. Here's their competitor, the interspinous spacer. And now more recently, the Coflex device, right? How about a Coflex device that you thought went in perfectly, and then 4 months later you see this? How about this? Writing this chapter, I've seen some things I've never heard of and never imagined. I've never seen a dynamic facet replacement device. Have you seen any of these, Ron?
Not that one.
So, and then of course, you look at the scan on the left, you're like, oh no, we forgot to put in the rod. Did we forget to put in the rod? No, it's in there. So what could be in my way? So, you're all excited, you're in the OR, you're ready to throw in screws. Next thing you know, you've got a pump there, right? If you're not prepared to know what level that catheter goes in, the next thing you're going to say is, oops. That's not a good start to a long case. You got to be prepared. What are you going to do with the pump? What are you going to do with the spinal cord stimulator? How am I going to get around it? And now the dreaded complications, right? You did the perfect case, you get your postoperative scan, you've got your pseudoarthrosis. You've got a broken screw. So how many screws do we have in on that left side of that image? Is it 2 screws? No, it's just the way that image is cut, and you have to understand that image is cut right where you're going to see both those screws. This was a case that where there was a CSF leak. Patient woke up with a cauda. What happened? Well, if you were in the OR, you know that maybe the dura was closed too tightly. This patient was taken back emergently for a duroplasty that same night. How about the unfortunate spinal cord infarct? The dreaded pseudomeningocele. You do not really want your nerve roots hanging out outside the thecal sac. It's not ideal. It's poor form. Your attending is not going to be happy when you see this scan. But how many times are you going to, patient wakes up with some leg weakness, post-op pain, and you see this scan. What's going to be the read on this scan? 100% epidural, can't rule out epidural hematoma, clinical correlation recommended. Are you ready to take this guy back? So you have to keep those thoughts in the back of your mind. Patient wakes up with stridor. Or you get that call at 3 o'clock in the morning, had a coughing fit, has stridor. You get a quick CT scan, you've got the supraglottic swelling. How about an infection? A discitis 3 weeks later. Or even worse, walled-off abscess. Here, training with Jens Chapman, Jens uses antibiotic beads. What if you've never seen that? You get a CT scan on a patient, from across town because they couldn't make it to his original surgeon. Do you know what those things are in the middle? Well, you have to be prepared to know they're antibiotic beads. How are they put in? What do you do with them? These are not ideal screw placements, and these are definitely not things you want to see on your postoperative scan. Part of this could be avoided by understanding your imaging intraoperatively. Patient wakes up with some leg pain postoperatively. Retained bone fragment, or even worse, a retained drill bit. What do you do for this? Do you go after it? Do you not go after it? What do you tell the patient? What do you tell risk management? Who knows what Gossi pyboma is? Anyone? So this patient had a surgery internationally, and they forgot a sponge. There are no markers on their sponges internationally, and I guess by definition, neuroradiologists call them Gossi pybomas. So they'll dictate that in their note. They may say retained sponge, or they may just say Gossi pyboma. So if you can't just run over to Wikipedia or PubMed to figure out what it is. You have to know all this terminology you're going to be reading. And of course, the dreaded cement extravasation. You know, you want to know when to put in cement, when not to put in cement. You don't want to be at a CT scan seeing this. You want to be able to recognize it first. And this is probably the worst when you get a pulmonary embolus out of it. So in conclusion, use your images at all stages, before, during, and after. Don't be afraid of them. Look at as many images as possible, not just as a resident, but also when you're an attending, when you're a fellow. You're always learning. Look at other people's images. Ask them. Ask your colleagues. Ask your neuroradiology colleagues. Collaborate with them. You know, if you're unsure, get another one. Always make sure to understand that the images do not lie. The only difference could be if the image was not the right image. And you then make the necessary corrections. And finally, learn from the bad and the ugly in your journey to become great.